This pharmacology topic is diuretics. Diuretics all work by promoting fluid elimination, but there are several classes that differ based on where they work in the nephron. So before we get into these classes, we first need to understand the parts of the nephron. Remember, there are thousands of nephrons located in the kidneys, and each can be thought of as a little filtration system for the blood. There are blood vessels that run alongside the nephron that provide the framework for the filtration and reabsorption processes that occur at each point in the nephron. Here you can see a magnified image of a single nephron, which we'll walk through together. First, the renal arteries bring the blood to the glomerulus, which is the bundle of capillaries in the middle of the image. This is where the waste products and other small molecules are filtered out of the blood and move into the nephron as filtrate. This filtrate will then move through the nephron. First, it will go to the proximal convoluted tubule, then down the descending loop of Henle and back up through the ascending loop of Henle. It then moves to the distal convoluted tubule and finally down the collecting duct, which is where it then leaves the nephron through the ureter for eventual elimination. Throughout this whole process, fluids and electrolytes are reabsorbed back into the blood or actively secreted out of the blood in order to regulate blood volume, concentration, and pH. Let's start with the class of diuretics that work earliest in the nephron, the carbonic anhydrase inhibitors. A common medication from this class is acetazolamide. Acetazolamide inhibits the carbonic anhydrase enzyme in the proximal tubule, which blocks reabsorption of sodium, chloride, and bicarbonate. Because water will always follow sodium, this will also prevent water reabsorption. Now, this diuretic class is unique as it also blocks the carbonic anhydrase enzyme in the eyes, which will reduce the production of aqueous humor. This reduction in aqueous humor helps to lower intraocular pressure, which is why the most common use of this drug class is for glaucoma. You may also see this drug used as an adjunct therapy in clients with edema, such as those with heart failure, who also have metabolic alkalosis to help restore acid-base balance. The class of diuretics that work in the next part of the nephron are the osmotic diuretics, such as mannitol. Mannitol works in the proximal tubule as well as in the descending loop of Henle to inhibit sodium and water reabsorption. Now, osmotic diuretics are different from the other diuretics as they don't actually block any enzyme or transporter. Instead, these substances are freely filtered in the glomerulus, but they're not able to be reabsorbed. This allows them to increase oncotic pressure in the filtrate, which will then pull water into the filtrate by osmosis. So in other words, the water will passively move from an area of high water concentration to low concentration to help achieve a balance. Now, these drugs are not commonly used for diuresis in clients with edema, as they may actually initially worsen volume status. They're instead used to reduce cerebral edema via a similar osmotic mechanism, which decreases intracranial and intraocular pressure. Next, we have the loop diuretics, which work in the thick ascending loop of Henle, and these are typically considered our most potent diuretics. Most of the medications in this class end in "ide", including furosemide, torsemide, and bumetanide. These drugs block sodium and chloride reabsorption, and again, because water follows sodium, this will also prevent water reabsorption. About 25% of sodium is typically reabsorbed here, so blocking this will cause quite a profound diuretic effect. Now, this drug class is often used to promote fluid elimination in clients with volume overload or edema. This occurs commonly in clients with heart failure because their heart is unable to effectively pump blood to the body, making the body activate several compensatory mechanisms to increase blood volume. But because the heart can't handle this increased volume, it becomes backed up in the lungs and lower extremities, leading to edema. Although these drugs will decrease blood pressure due to fluid loss, the potent diuresis effect is often not tolerated in clients who have hypertension without volume overload. So loop diuretics will not typically be used for the sole treatment of hypertension. Loop diuretics may also be used in patients with renal impairment to help with excessive volume in the setting of decreased urine output. You may see that these clients require higher doses to achieve effective diuresis, simply because their kidneys are not working well enough to get those lower doses to the site of action. Now, to remember the common adverse effects related to loop diuretics, think of hypo, as these drugs can cause hypokalemia, hyponatremia, and hypotension. The electrolyte imbalances caused by loop diuretics, including decreased potassium and sodium, are directly related to how these drugs work to cause that diuretic effect by blocking their reabsorption. These electrolyte abnormalities should be identified and corrected promptly, as persistent low levels will increase the client's risk for arrhythmias. Also related to the mechanism of these drugs, some clients may experience excessive volume loss, which can lead to hypotension and dehydration. Both blood pressure and fluid status should be monitored closely with the use of these drugs. Loop diuretics have also been associated with ototoxicity, including hearing loss and tinnitus. Risk of this adverse effect is increased with rapid intravenous administration and if used in combination with drugs that are also ototoxic, such as aminoglycosides. Loop diuretics can cause increased reabsorption of uric acid, which can lead to hyperuricemia and potentially precipitate a gout flare in susceptible clients. Finally, diuretics can increase the risk of lithium toxicity. Lithium is a mood stabilizer, which is primarily cleared through the kidneys as unchanged drug. Due to the effect of diuretics in the nephron, less lithium may be eliminated, leading to increased blood levels and adverse effects. The next class of diuretics, which work in the distal convoluted tubule, are the thiazide diuretics. These include hydrochlorothiazide, chlorothiazide, and chlorthalidone. These drugs have a similar chemical structure to sulfonamide antibiotics, and this is important to know as these antibiotics are often associated with allergies, so there is a risk of cross-reactivity with thiazides. Now, similar to loop diuretics, thiazide diuretics also block the reabsorption of sodium, chloride, and potassium. So again, this will also lead to decreased water reabsorption. However, only about 5% of sodium is reabsorbed in the distal convoluted tubule, so this will mean a much milder diuretic effect. This diuretic effect is even further diminished in clients with renal impairment, as these clients will have more proximal sodium reabsorption, so there's even less sodium delivered to the distal part of the nephron. Because there's no sodium reabsorption to block, thiazides will have little to no effect. Now, thiazide diuretics are used most often for the treatment of hypertension, as the mild decrease in blood volume will lead to decreased blood pressure. They can also be used in conjunction with loop diuretics for clients with heart failure who are difficult to diurese with loop diuretics alone, as this addition will target two parts of the nephron rather than just one. Now, the adverse effects of thiazide diuretics are similar to those of loop diuretics. Electrolyte imbalances, including hypokalemia and hyponatremia, are the big ones, and again, these are directly related to their mechanism of action. Unlike the other electrolyte changes, thiazides will actually cause an increase in calcium levels by increasing calcium reabsorption in exchange for sodium. Now, similar to loop diuretics, thiazides will also increase reabsorption of uric acid, putting clients at an increased risk of a gout flare. Thiazides have been associated with increased blood glucose levels. Now, the exact mechanism of this is unknown, but it's thought to be related to decreased insulin secretion and increased insulin resistance. Thiazide diuretics may also increase the risk of lithium and digoxin toxicity. Remember, diuretics may decrease lithium clearance, which leads to increased blood levels. And even a small change in blood levels can increase the risk of lithium toxicity. On the other hand, the risk of digoxin toxicity increases in the presence of hypokalemia and hypomagnesemia, which we just mentioned are big issues with these drugs. This can cause toxicity to occur even with normal blood levels of digoxin. Now, though the diuretic effect is mild, Clients are still at risk for dehydration if excessive fluid loss occurs. Thiazides can also cause increased skin photosensitivity, as they essentially decrease how much UV light is needed to cause the skin to burn. And last but not least, caution should be used if a thiazide is used in clients with a history of a sulfa allergy because of the potential of cross-reactivity between thiazides and sulfonamide-derived antibiotics, again, because of that similarity in chemical structure. The last class of diuretics is the potassium-sparing diuretics, such as spironolactone and triamterene. These work in the collecting duct of the nephron, so at the very end. All potassium-sparing diuretics cause inhibition of sodium channels in the collecting duct, either directly or indirectly. This leads to decreased sodium and water reabsorption and increased potassium retention. You can think that by working in the collecting duct, these drugs will cause the body to collect potassium. Now, a couple of the potassium-sparing diuretics, spironolactone and eplerenone, are also known as aldosterone receptor antagonists because these drugs will indirectly block the sodium channels by blocking aldosterone from binding to its receptor. Remember, aldosterone typically saves sodium and loses potassium. So if its action is blocked, then instead we will lose sodium and save potassium. Because these drugs work at the end of the nephron, they are very weak diuretics as not a lot of sodium is reabsorbed here. Instead, they may be used in combination with medications that cause hypokalemia, because remember, these drugs can cause hyperkalemia, so the combination will balance out potassium levels. The aldosterone antagonists may also be used for indications where blocking the action of aldosterone is beneficial, such as in heart failure and resistant hypertension. Clients should be educated to take diuretics in the morning to allow for maximal diuresis to occur during the day, and this will minimize the client having to wake up at night to go to the bathroom. Remember, electrolyte imbalances are a significant issue with diuretics, and if left untreated, can increase the client's risk for harmful events including arrhythmias. So electrolyte levels should be routinely monitored. The fluid loss with these drugs may cause hypotension, so blood pressure should be monitored and clients should change positions slowly to avoid orthostatic hypotension. For loop and thiazide diuretics specifically, clients should consider increasing their dietary potassium intake if needed, as these drugs can cause varying degrees of hypokalemia. Clients should also monitor for signs of dehydration, as excessive fluid loss can occur. Clients with diabetes who are taking thiazide diuretics should monitor their blood glucose closely with drug initiation and titration due to the risk of hyperglycemia. And finally, for potassium-sparing diuretics, the primary education points revolve around their risk for hyperkalemia. Potassium levels will need to be monitored closely for all clients, and even more so if the client is receiving other drugs that increase potassium, such as ACE inhibitors or angiotensin receptor blockers. These clients should also avoid potassium-rich foods to decrease the risk of developing hyperkalemia. Clients should be educated to read food labels closely, as potassium may be hiding in foods they commonly consume.